Hi, everyone. This is our presentation on inpatient rehab, our environment of practice. Inpatient rehabilitation facilities are utilized when a patient or client needs to remain inpatient for rehabilitative care. The length of stay can be anywhere from a few days to a month or more, depending on individual needs and specific client goals. In inpatient facilities, patients require daily supervision by a physician and nursing staff. The physical setting of an inpatient facility varies by each individual facility. Some inpatient facilities are standalone rehab centers, separate departments of a hospital, or nursing clinics. Within an inpatient rehab facility, there are typically patient rooms similar to those you would see in a hospital that are either private or shared, a designated rehab gym or space with rehab equipment, and several other amenities that may include dining spaces, recreational rooms, mock kitchens and apartments, garden or horticulture centers, creative therapy areas, and indoor-outdoor pools and spas. Inpatient rehab facilities treat patients with a variety of medical needs, ranging from neurological conditions following an illness, stroke, brain and/or spinal cord injury, amputations, multi-medical traumas, cardiac care, and much more. Inpatient rehab facilities are included in the physical health continuum of care and is often the third step for many individuals. As we discussed in class, individuals in inpatient rehab facilities may have been admitted to the emergency room and then received acute inpatient care before being admitted to an inpatient facility. Following discharge from an inpatient facility, patients will often receive services in a skilled nursing facility, through home health, or in outpatient services. Direct care is delivered to patients through intensive therapy for a minimum of 3 hours per day, and patients must require both physical therapy and occupational therapy services. Therapy will address physical and cognitive health within various domains, including activities of daily living, instrumental activities of daily living, work, play, leisure, social participation, education, and rest and sleep. Services are marketed directly through healthcare networks, and oftentimes you will find brochures in doctors' offices and hospitals. Referrals are often made by medical personnel. Additionally, local facilities are often advertised in magazines, newspapers, and online advertisements. Inpatient rehab facilities require a large multidisciplinary team of professionals, including physicians and specialists, nursing staff, physical therapists, occupational therapists, speech therapists, nutritionists, social workers, counselors, care coordinators, and others, according to the specific needs of the patient and diagnoses that are seen and treated within the facility. During our interview, we asked questions regarding job roles and responsibilities, supervision and management, as well as productivity. One of the questions we asked our interviewee was, how is the work divided and accounted for among the care team in your facility? What job roles and responsibilities do each members of the team have? And what are the typical productivity expectations for each team member? In what ways do you feel that these roles and responsibility delegations contribute to the overall success of intervention? To which our interviewee responded that in her facility, typical productivity is 6.5 hours of treatment time. There are 30 minutes in the beginning and end of the day for chart review and documentation. If patients refuse a session or miss time for any other reason, they are encouraged to pick up missed time or to see patients who are not scheduled for 3 hours that day. Occupational therapists are responsible to evaluate and treat patients and typically have 6 people on their caseload. They are responsible for their treatment plan, discharge recommendations, and ordering DME. CODAs, to which this facility only had one, is responsible for carrying out treatment plans, and rehab aides and techs are responsible for wheelchair assembly and assisting the therapists as needed. The interviewee described that she feels the job responsibilities are pretty standard and that they contribute to the success because individuals know what they are supposed to do and how to do it. An additional question that we asked was, what is the structure of supervision in your facility? Is the supervisor an OT, PT, nurse, etc.? How do you find the chain of command contributes to the overall success of your facility? To which she responded, there is an inpatient rehab manager who supervises all therapy staff. The manager for our inpatient unit is a physical therapist, as is the supervisor who is above him. There is a nurse manager and physician on call at all times, but there is limited interaction with them unless it is regarding patient care. She said that she feels as though the chain of command makes staff feel removed from management, and they feel as though they don't have say in some of the higher up decisions. The old therapy manager there would spend half of the day treating and half doing managerial things, which she felt was the better approach.
Okay, so now I'm going to talk a little bit about funding with occupational therapy services. So basically, we want to look at how services are reimbursed and additionally primary sources of funding for services. So as I have here on the slide, funding, you really want to show that there's a medical necessity for treatment and continuation of treatment. So there must be a justification for the treatment with goals that are consistent with OT scope of practice. They contain the proper coding and have functional goals that clearly express progress and plans to address clients' barriers. Keyword here being clearly, which will come with practice and experience in the field and repetition when writing client notes. Also here I have an example of an ICD-10 CDM coding that's shown just below. And these codes enable OTs to classify diagnoses and the reasons for visitation and continuation of treatment. Specificity matters. OTs should really remain up to date on the coding process as they're liable to change and constant update in time. As I previously mentioned, below here you have the coding, which in this case is written to document a posterior dislocation of the left acromioclavicular joint. You can see the 7-digit coding here. Also, there are CPT codes, and the CPT codes provide a degree of standardization as well and are generally 5 digits long. These codes can also reflect the level of complexity of clinical decision-making, and the codes 97165, 66, and 67 all range from low, moderate to high level complexity, respectively. Also, there's a code 97168, and this code's used for documenting reevaluation. And some sources of funding here I'll briefly discuss. So all in all, about half of funding comes from private employee-based insurance. Picture here shows some of the biggest insurance companies in the US, companies like Cigna, Aetna, MetLife, etc. And also, where there's no universal health care in the US as is done in other countries, Medicare does provide a great deal of funding for OT services for many Americans. And last here, we have an excerpt from the interview we had with our OT interviewee about typical sources of funding in the facility in which she works. She had remarked that Medicare funds the majority of our facility. We are a not-for-profit hospital system, so insurance reimbursement is how we fund our care. We have an outpatient rehab facility downstairs, and they bring in most of the revenue to support the inpatient rehab. Next, we'll discuss the accreditation process of rehab facilities.
Accreditation of inpatient rehabilitation facilities is achieved through the Commission on Accreditation of Rehabilitation Facilities. The steps to becoming accredited include, first, a consult with your designated commission resource specialist, and this is to receive guidance and technical assistance regarding the accreditation process. Second, conduct a self-evaluation. Typically, the service provider, like someone at your inpatient rehab facility, conducts a self-study and an eval of how they are going to meet the standards. Third, you submit the survey application, and the survey application includes detailed information about leadership, the programs and services provided at the inpatient rehab facility. Fourth, the commission invoices for the survey fee. This is typically a fixed fee with additional fees if additional programs are added to the survey. Fifth, the commission selects the survey team. Surveyors are selected by matching their program or administrative expertise and relevant field experience with the service provider's unique requirements. The survey team conducts the survey and determines the service provider's conformance to all applicable standards on site by observing services, interviewing persons served and other stakeholders, and reviewing documentation. Seventh, the commission renders the accreditation decision. The commission reviews the survey findings and renders either 3-year accreditation, 1-year accreditation, provisional accreditation, or non-accreditation. The results of the survey typically take 6 to 8 weeks to receive, as well as a report of the quality improvement plan. Eighth, The facility has to submit a quality improvement plan within 90 days of the service provider fulfilling it. 9, they have to submit an annual conformance to quality report. This needs to be submitted on the anniversary date of each year following the award. And 10th, the commission maintains contact with the service provider, helping them throughout their accreditation tenure with whatever they need or any help that they need meeting the standards.
Next, we'll talk a little bit about ethics and liability in this inpatient rehab setting. So talking about some of the ethical issues and the processes to address them, a lot of ethical issues that come up have to do with providing quality care for reimbursement while also maintaining the required level of productivity. And so there's this challenge of maintaining high caseloads and offsetting the per client reimbursement while also managing proper documentation with less time. And that poses quite a challenge to OTs in this setting. AOTA says that OTs have difficulty meeting these expectations and at the same time practicing efficiently, legally, and ethically. Some examples that could occur of ethical issues have been charging for unprovided services or using students for billable service, coercing a client to participate in therapy despite them not really wanting to, productivity standards that are not realistic, and being forced to choose between giving quality care or keeping your job. In addition, our interviewee said that most of the ethical issues she has encountered in the inpatient setting are patients patients who are on a thickened liquids diet, drinking thin water, or an NPO patient eating. She said that steps that they are trying to take to decrease these are they're completing monthly step-ups, they call them, which are educational refreshers on certain topics like pressure injuries, orthopedic precautions, and then other things that they encounter in the day-to-day. Other strategies that we found that would rectify ethical issues were called ethics rounds, where interprofessional teams discuss potential ethical issues for patients when they're creating the interventions. Some more ethical problems that can occur: determining the length of stay. There are soft endpoints where the aspects of function are on a continuum, so it's hard to decide when discharge is appropriate for patients. Length of stay sometimes plays a bigger role in determining rehab goals than what would be ideal. Additionally, the American Medical Association states that physicians should always advocate for the need of their patients. In our interviewee said that most patients stay for 10 days, and studies also showed that even a 7-day stay in an inpatient rehab is effective. But again, it's important to always advocate on behalf of the patient. And then additionally, the AOTA Code of Ethics is just a document that addresses ethical concerns in the profession and outlines standards of conduct for OTs to adhere to. Some issues associated with liability are negligence by an OT. So according to a report published in 2017, something that occurred was that an OT did not monitor a patient correctly and the patient fell while reaching for the sink. And this claim was settled for over $145,000. Another example is not following a practitioner orders. So a practitioner might order no weights to be used on a rotator cuff repair. And if the OT were to use the weights, the patient could get re-injured. Patients can also get burns from modality use. So if an OT incorrectly applies or does not supervise in the inpatient setting with either stroke or TBI where there's limited sensation, then that could burn the patient. And kind of like I mentioned before with the re-injury, not treating the patient properly and accidentally re-injuring them. So for example, would be not following hip precautions. And moving on to policy and legislation, there are some acts that are important to the field of OT. So specifically the Patient Protection and Affordable Care Act. This protected, some of the things that it protected were the OT scope of practice for orthoses and prosthetics, which are commonly used in the inpatient setting. This act allowed the OTs to maintain their scope of practice in orthoses. And then it also enabled individuals and small businesses to purchase health insurance policies subject to certain requirements. So it made insurance more affordable, and it affected OT because it allowed previously uninsured patients to receive those occupational therapy services. It also expanded Medicaid eligibility. So it moved it to 133% of federal poverty level, and it also increases federal funding to cover additional costs. It's important for receiving expensive inpatient services. Then another one is the Improper Payments Elimination and Recovery Act of 2010. This made sure that therapists were documenting correctly and was required by CMS when they produced the fee-for-service improper payment rate. And then on there, we just have Medicare. Although it's not an act, it's coverage and reimbursement for patients for things such as swing beds, criteria for being in the inpatient setting, new admissions and payments, or what it kind of covers and talks about. The OT we interviewed, as Andrew said before, said that Medicare funds the majority of their facility. They are not-for-profit hospital, so insurance reimbursement is how they fund their care. And then additionally, just some opportunities for advocacy. It's important for an OT to advocate for patients. This can include going the extra mile to making sure a specific wheelchair is covered by the insurance, or putting patients in contact with local resources in their area upon being discharged. Additionally, self-advocacy and advocating for the OT profession is important. This can be advocating for extra funding in your unit, asking for new equipment, being a supervisor or a manager of your rehab department in the inpatient setting. And then also the AOTA carries annual events such as the Virtual Hill Week, which is about advocating for the profession, Capitol Hill Day, where OTs speak to Congress about pending legislation. Also, being a member of AOTA and the state association in which you work supports the whole profession. And you, as an OT, represent your environment of practice when you're advocating.
So 2 areas of innovative topics that could be identified when it comes to program development are community reintegration programming and also assistive technology training. In the case of community reintegration programming, there was a paper written that was published by the AOTA by a practicing OT about a community reintegration program that was implemented as a pilot program in Nashville, Tennessee at TriStar Skyline Medical Center after a needs assessment was performed that identified the need for community reintegration training while in inpatient rehabilitation, which has outcomes such as better transition from hospital to home, and it also enhances community participation after discharge. Some of these direct benefits for that patient would be increased life satisfaction, increased confidence and self-efficacy, and increased independence with all of their occupations, such as ADLs and IADLs. This paper also specifically identified that when patients are discharged back into their home, they do things such as going to restaurants and going shopping and things like that. And a program such as this would more directly have them practicing those skills necessary to be able to complete those occupations when they are discharged. As far as the assistive technology training, the paper that specifically identified this need was all about the use of tablets and the benefits of the use of tablets with clients in inpatient rehabilitation are that they're very client-centered, which Sumsian and Law wrote about how this is the primary basis for OT practice around the world now. It's very easily customizable. The use of technology and tablets involves infinite number of applications and different ways that it can be used. It improves functions such as visual function, fine motor function, cognitive function such as memory, attention, and organization, as well as communication for patients using them. And then other benefits also include that it assists with client education, that tablets can be utilized when helping to educate clients about their rehabilitative process, as well as even recording sessions of treatment so that then later they can take that session home with them to revisit and practice those same activities and skills. And then as far as implementation of proposed programming, specifically in the case of the community reintegration programming, as an example, the roles that OT can take on are both leadership and advocacy when developing and implementing this program, as well as administrative roles when it comes to gaining the resources that are needed. And the resources that would be involved in a program like this are finding the funding, as well as the time to plan and execute a program like this. When we were speaking to our practicing OT in the interview, one of the main things that she identified is that in inpatient rehabilitation, there is a limited amount of time to be working with those patients. So you have to be as productive as you can be as quickly as possible. So one of the main resources for a program like this would just be the time to actually do it. And then as far as material resources that may be needed are the transportation to and from places like stores and restaurants to practice those skills. In some cases, educational materials may be necessary. Access to practical locations would be needed. In a hospital situation, this can include things like the gift shop, the cafeteria, and other places like that, also pharmacies. And then lastly, interdisciplinary collaboration would be the most beneficial for making a program like this successful, because other professions can utilize this, such as PT with evaluating balance and mobility, and speech language pathologists for the speaking and eating aspects that can be implemented in this program.
From our interview, we were able to gain more insight on the inpatient rehabilitation setting. We mentioned the results of most of our interview questions throughout the presentation, but additional information we gained through the interview included asking our participant what they would change about their current inpatient rehab facility. They shared that they would change the overall dynamic and staff responsibilities. When they shadowed at another inpatient rehab facility, patient care technicians were readily available to help, and it felt like that it was a team approach. Where they work, it feels a little disjointed at times and can feel like you are working alone to advocate for your patient. We also asked, how do they approach treatment in an inpatient facility versus other practices like home health, outpatient, and etc. They shared that in their inpatient facility, there is very limited time to be spent with the patients. The average length of stay is about 10 days. So you have to prioritize treatment goals and ensure you are working with your interprofessional team to make the most out of their stay. This is sometimes challenging. While you want to be patient-centered and work on what the patient wants to work on, sometimes it is most important to work on the basic activities of daily living and other practical things. And here are our references. And then we have key references as well with a brief description. And lastly, we have annotated references. And that brings us to the end of our presentation. Thank you.